Adenomyosis is a disease that poses a threat to women's health and affects reproductive function. The pathogenesis involves the growth of endometrial cells into the uterine muscle wall. The main clinical features are dysmenorrhea and excessive menstrual bleeding. It can lead to infertility, recurrent miscarriage, ectopic pregnancy, biochemical pregnancy, etc. The characteristic of adenomyosis-related dysmenorrhea is secondary dysmenorrhea. It starts painless and gradually becomes painful and progressively worse. The pain intensifies while simultaneously experiencing infertility or natural miscarriage, which raises a high suspicion of adenomyosis. Diagnosis relies on ultrasound, particularly high diagnostic accuracy with panoramic 4D color ultrasound at Beijing Antai Hospital. It not only determines the size, location, and severity of adenomyosis lesions but also identifies degenerative changes in the lesions. Diagnosis is straightforward, but treatment is challenging. Many hospitals use GnRH agonists, which act on the hypothalamus or pituitary gland, causing physiological axis suppression and amenorrhea. Common medications include danazol, dienogist, and leuprorelin. Using medication provides temporary relief but does not address the root cause and can result in significant menopausal symptoms. Moreover, these medications also act as contraceptives, which worsen infertility in patients. Another treatment option is hysterectomy, which is even less favorable for infertility treatment. After a hysterectomy, there are no menstrual cycles, let alone the possibility of pregnancy. To conceive, options are limited to in vitro fertilization, IVF, or surrogacy. A U-shaped resection, removing a portion of the lesions on the uterine wall, offers slightly better outcomes than the previous methods. It is effective for mild cases with small lesions, but it has two major drawbacks. First, incomplete resection leading to a high risk of recurrence, and second, postoperative changes in uterine morphology from pear-shaped to altered shape. This can result in continued infertility or the development of intrauterine adhesions and pelvic adhesions. The most advanced technique is the use of Antai Hospitals' apoptotic agent for ectopic cells. Under the guidance of laparoscopy and ultrasound, the apoptotic agent is injected near or directly into the adenomyosis lesions. Hospitalization for about 7 days, and the uterus returns to normal after 1 month. Adenomyosis cells are not the same as uterine muscle cells, and they are completely different from endometrial cells. The apoptotic agent causes the lesions to undergo apoptosis, shrink, and be absorbed. This technique is highly advanced and is comparable to using weed killer in a field, where crops thrive while the weeds die. Its best feature is that it does not affect the endometrium. Some believe that endometriosis is the migration of endometrial tissue into the muscle wall. No, the apoptotic agent proves that they are not the same type of cell. Because it acts on the adenomyosis lesions while the endometrium remains unaffected. It does not cause intrauterine adhesions, reduced menstrual flow, or even amenorrhea. Antai Hospital in Beijing offers a signed treatment agreement. If there are still adenomyosis lesions, or if there is still dysmenorrhea or infertility upon re-examination, a full refund is provided. When requesting a refund, objective indicators must be provided. A refund cannot be requested based solely on dysmenorrhea. The FAIR criterion is the absence of lesions detected by ultrasound, indicating successful treatment. This approach helps patients avoid excessive treatment that may lower their quality of life and prevent them from incurring financial losses.